Hello, everybody. I'm Bob Croyle, and I'm the former director of the Division of Cancer Control and Population Sciences, now senior advisor that my successor has just started. And it's my pleasure to open up this session, and I'm going to kick things off and provide a little bit of a broad context for particularly NIH's role in health disparities and health equity research and application, and make some historical parallels, particularly to some movements in US history known as the Great Awakenings. The Great Awakenings, if you're not familiar in American history, there were either 3 or 4 of these, depending on who you talk to, but I'll mention just the first 3. In the 30s and 40s, a movement really that preceded but helped catalyze the development of the American Revolution. A second in the 1820s and 30s, which was really key to development of the abolitionist movement and other movements, the development of new religious sects in the 20s and 30s leading up to the Civil War. And then a third, starting before but continuing after the Civil War, that really led to a number of social movements in the US, women's suffrage, a number of social causes in terms of addressing the poor and underserved. And these had some common themes, which I think relate to what I'm going to argue this past year and a half has been a great awakening at the NIH. The religious revivals that oftentimes had atonement of sins as a major theme. What have we done wrong? How it can focus more on moral values as opposed to economic values. So in part in the late 1800s, it was a reaction to social Darwinism. Political mobilization, oftentimes a feature, but oftentimes characterized by sharing personal emotional experiences about disenfranchisement and victimization of the culture and system. Many products of these movements, development of new universities as a result, Princeton University, Brown, Dartmouth, all tied to Great Awakenings, the social gospel movement and addressing poverty and inequity, but also murder as a catalyst. Elijah Lovejoy's murder in 1837, he was a martyr of the abolitionist movement, was really key. And in the case of the NIH and the NCI, so let me talk a little bit about NCI and cancer research. Prior events and important sparks, but that didn't lead to what I would call a fire or the current Great Awakening that we're seeing at NCI and NIH. Gil Friedel, for example, becoming the first cancer center director, declared that alleviating poverty and serving underserved populations was going to be his main strategic mission as a cancer center director. He led, but not many followed. Many of his colleagues thought he was a little bit strange and weird for doing this. NCI director Sam Broder saying in 1989 that poverty is a carcinogen, which every few years has been cited by organizations, but at the time didn't lead to a major fire. Kahn and Prager, among others, arguing that the importance of developing interdisciplinary research to inform health disparities and health equities work. The unequal burden of cancer, the IOM report that was so key in 1999, and again, stimulated discussion, but not as big of a response as we would have wished. We paid a lot of attention to it at NCI, but it could have had a broader impact and identified a lot of our current issues. Acting NIH Director Ruth Kirstein, bless her, the late Ruth Kirstein, who when she became acting NIH Director, launched the first agency-level health disparities initiative and required for the first time every institute to develop a disparities and equity strategic plan. And then our first big research initiative in this area, the Centers for Population Health and Health Disparities, RFA, that we did with several other institutes, and for 10 years launched these new centers, which again didn't lead to a revolution, but actually trained a lot of the junior investigators that are now the leaders in the field. But there was a lot of passive resistance, sometimes active resistance. Part of this, I think, was disciplinary bias. A lot of our understanding of health disparities and health equity came out of the social sciences, which were not only not familiar to many basic and translational scientists who just didn't take those courses as undergraduates, but disrespected and second class. This isn't real science. This isn't quality science. The sense that it's such a big, large, and complex problem, how can we even take it on? Why should we allocate resources? It's so difficult. It's kind of like saying, you know, the molecular target is not druggable, so you can't even treat it. Why should we even try? It's not NIH's mission. Shouldn't CDC be doing this? HRSA, other agencies, nonprofits, American Cancer Society. It's too political. Gee, if we get into this area, we're going to be upsetting people. These are controversial topics. When we released our first program announcement several years ago at NCI, focusing on racism and its role in healthcare, it was very controversial. Healthcare delivery is about policy. It's not science. This isn't research. It's all about politics and health policy. That's not our domain. So an underappreciation of the role that evidence can play in driving policy. And also kind of a neglect of primary care several years, less so these days, in a specialty care focus agency. Institutes are organized around diseases, not primary care and complex healthcare. Multimorbidity in the real world versus the patients seen in clinical trials. And again, not generating the evidence about practical situations faced by primary care, especially in underserved populations. So solutions and some actions I think that have been very important that we can build upon. Effective informed leadership across all of our organizations is absolutely key. Without committed leadership, like Eliseo, who himself has a general internist background, long track record and expertise in health disparities, that's really key. Continued integration of social and biomedical sciences and training, I think, is important. Robert Wood Johnson Health and Society Scholars was really transformative, I think, in this area. Revitalizing Agency for Healthcare Research and Quality. So this is my personal opinion, but really an expansion of research on healthcare systems is what we really critically need in our country. Strengthening health equity relevant performance measures and standards. I think the National Quality Forum is doing good work in this area. Tim Mullet will talk about Commission on Cancer. Increased support for and flexibility of CDC's cancer control programs. NIH has seen budget growth. The cancer control program at CDC has not. It needs more funds and it needs more flexibility in how to spend those funds. Strengthen NCI's cancer centers programs, particularly their community outreach and engagement requirements. We put in that requirement a few years ago. I think it's been transformative, but it's largely an unfunded mandate, and we can build upon that with additional funding. Greater investment in health disparities and health equity research, but especially including implementation science. We've seen during the COVID epidemic what happens when you roll out a new vaccine, but without a lot of good implementation science evidence to overcome vaccine hesitancy. Let's not relive that lesson again. Let's support this area of work, policy work, research, and also international comparative studies. We need to have more humility in the United States and learn more lessons from other healthcare systems. I'm proud to say that in the Division of Cancer Control, the one I've led over the last several years, in the last 4 years, we've doubled our research funding for health disparities and health equity research. So we're on a great upward trajectory. We want to sustain that, and hopefully over the next several years, we will do that. But good progress. The NIH Awakening then of the 2020-21, I really think it has been a remarkable transformative awakening, like these social movements in the US. Catalyzed, of course, by the murder of George Floyd and many other events, but remarkable that earlier this year, the NIH director publicly apologized for structural racism in NIH funding. So this is the atonement of the awakening, right? Rapid proliferation then at the entire agency of new planning, research, training, cultural initiatives, changing the culture of the agency, which is important, like the Unite initiative is one example. And many examples, here's a couple of recently funded ones. At the NIH level, using the NIH director's discretionary funding, the Common Fund, for major commitments for health disparities and health equity research. So I think there has been a great awakening at our agency, and we're only one player in a complex landscape. But I think I see this happening at academic institutions and many organizations. And this great awakening is something we can all build on for the future. Thanks very much.